so much. Bismillahirrahmanirrahim. Assalamu alaikum ji. I just want to thank the organizers and of course Professor Tafazul, Professor Flark, and all of you, and especially at this point I'm going to thank Professor Nighat for coming this early for my presentation. I wish he hadn't, because now I'm going to get very nervous. But thank you so much for this invitation. So these are my affiliations and these are my disclosures. Off-label disclosure is that I had house guests that just left yesterday, and so this presentation has been put together in 24 hours. And I'm a grandmother, so my little babies were continuously coming in and deleting whatever I was doing. So these are my references. And I am going to, this was a very large area to cover, so I have just restricted to the biologics primarily that are available in Pakistan, and their indications in two particular JIA subtypes, which are the enthesitis-related arthritis and psoriatic arthritis, with the two case narratives on psoriatic arthritis. I will briefly touch upon the other subtypes as well. So we all know what JIA is. It is an arthritis of unknown etiology, and it is important to remember that all other known conditions must be excluded, begins before 16 years of age and persists for at least 6 weeks. And the pattern over 6 months determines the subtype. Now, pre-biologic, we know that persistent disease existed in almost 70% of children with polyarticular and also what is juvenile SPA, and long-term disability was seen in 30 to 40%, with severe disability in 10%. As you can see, this is an encouraging graph where it shows that post-biologic, there has been remission of medication for almost 47%. So this is the glass full, but we see that there's still a lot of children that are still on medications and unable to taper their steroids. Therefore, despite these advances, we can see that remission rates are still only approximately 35% or at best 60%. Patients with uncontrolled disease face progressive joint destruction, gait dysfunction, and altered growth. And particularly children with psoriatic arthritis or enthesitis-related arthritis have a relatively poorer prognosis with significant disease-related morbidity. These patients are more likely to experience disease flares and have an overall lower health-related quality of life in comparison to other subtypes. Studies have shown that secukinumab, an IL-17 inhibitor, improves enthesitis, dactylitis, and the swollen and tender joints in adult populations with spondyloarthropathy. And recently, this has been approved for children and adolescents with ERA and juvenile psoriatic arthritis. And it seems to have decreased the time to flare and sustained improvement of signs and symptoms in treated patients. And it is a great addition to the juvenile arthritis population. We know that JIA is divided into several subtypes. I won't go over these. I just want to say that we are going to talk about ERA and psoriatic in greater detail. I know that many of these are associated with HLA-B27. Some of the psoriatic ANA positives can have uveitis as well, and there is significant disability due to enthesitis and dactylitis that is difficult to treat. So this is a 5-year-old girl who had a symptomatic left cataract, which picked up due to difficulty reading in preschool. You know that these children are usually asymptomatic because they actually adjust to their disability very quickly. There's a 1-year history of a single swollen joint, which was initially attributed to trauma, and the x-rays and blood tests, including rheumatoid factor, was negative, and ANA done at this point when she was sent for the cataract came out positive, and she was referred to us in rheumatology. And a detailed examination revealed another swollen joint and rash on extensor surface legs, and dermatology confirmed skin psoriasis. So this is psoriatic arthritis with dactylitis and chronic anterior uveitis. Just a reminder that uveitis is the most common and potentially the most devastating extra-articular manifestation seen in JIA. And JIA-related uveitis has a worse outcome compared to other etiologies of idiopathic uveitis. And the treatment protocol briefly for JIA-related uveitis, in addition to topical corticosteroids and cycloplegics, is to start with methotrexate, and then there is graduated first indication adalimumab, then moving on to infliximab or golimumab, which is not available, sorry. So I'll say adalimumab and infliximab in Pakistan. Tocilizumab, as well as rescue treatment like abatacept, rituximab, which is available, and inhibitors of JAK kinase, which are again now available in Pakistan. The other conventional DMRs like azathioprine, mycophenolate, and cyclosporin have been used. It is important to know that uveitis can continue despite resolution of arthritis, and therefore you must keep a close watch on it. This is a 14-year-old child whose history goes back with reluctance to get out of bed in the morning, and parents felt the child doesn't want to go to school till he developed a slight limp, and it was shown that he has a swollen left Achilles tendon. His counts were normal, ESR was normal, and he used to play football, so they thought maybe it's just trauma. Later on, the same child developed a swollen toe, and again, because initial attribution to trauma, but then when blood tests, it didn't resolve, and blood tests were done, he came back unfortunately with a raised uric acid. And you know that we see a lot of prescriptions where anyone, whether it's a child or a premenopausal woman or anyone with even a slightly raised uric acid, it is considered gout, and so this child was treated as gout. After 6 months, there was increased swelling of the right knee with a recent limp, and when he was examined, he had a right knee which was swollen with a slightly high ESR, and uric acid was raised, and so he continued to be treated as gout. Later on, the swelling had resolved, but at 23 years, he came back with a low back pain, bilateral gluteal and upper thigh pain, which had been there for 3 years, and this was again initially attributed to trauma. And on examination of his labs, he had a high ESR and a normocytic anemia. So the first question, this was a unilateral sacroiliitis, was that could this be tuberculosis? And a bone scan revealed increased uptake, and so anti-tuberculous therapy was initiated. However, it is important to remember that the other thing that should not be missed is that this could be ERA. And this is a very good article which shows how unilateral sacroiliitis in tuberculous infection can be differentiated from sacroiliitis that is seen in psoriatic arthritis. So more than ERA, in which you can see more bilateral, actually psoriatic arthritis can have just unilateral sacroiliitis. However, he was initially, diagnosed as having ERA, and his HLA-B27 came back positive. So he had been admitted for these investigations because his company covered him for inpatient tests. And at that point, a very conscientious house officer on the 3rd day of admission took off his socks during examination. So please remember to expose everything in your patients. And when he did, he saw dry scaly soles, and he also had a long-standing history of scalp, which was, they thought was dandruff. And this actually was juvenile onset psoriatic arthritis. I'm sharing this, and I've shared this a few years ago, actually, when there was a launch of secukinumab. This is a patient who came in, started with this story in the center, and then he landed up finally, because he was lost to follow-up, he went on her key medications, all of the things that happen to our patients. And when he came, he actually was locked in. There was absolutely no movement at hip, knee, shoulder, hands. He had florid psoriatic plaque psoriasis. And his brother had been nursing him for the last year plus, literally carrying him to the bathroom and back. And I remember this was the time we were in Fatma Memorial, and secukinumab had just been introduced, and through Arthritis Care Foundation, we actually managed to arrange the injections for him. And I also remember how happy and excited we were. And you know, we had arranged it. It was supposed to be brought in the next morning. When I came to the hospital, unfortunately, we lost him. And it is very important not to lose sight of the fact that it's not the numbers that we treat. These are real living human beings. And particularly with children, I think for all of us, we have a soft spot. This child, this man now, was very fond of poetry actually, and his brother told me this, and he allowed me to use this, that he used to say at the end, he was fond of fairs. And as you know, this Aaj Bazaar mein pa bachola chalo, phir hami qatl ho aaye yaro chalo. And the most important message, I think, for all of us is life and death is in Allah's hands, but the quality of life definitely is something that we as physicians have to be very cognizant of. I'm happy to share this child who actually came 2 days ago, who was in a similar state when he came to us. His mamu is a doctor in services, and we tried a lot of things. He was resistant to conventional treatment. He was resistant to anti-TNFs, to tofacitinib. He got some toxicity with that. He had to have a hip replacement on the right side, and he literally was brought in a wheelchair several times. And then we managed to arrange secukinumab for him, and he walked in and he's looking so good. So I'm not saying that the thing is, you keep trying and you keep finding ways to resolve situations, and yes, you can prevent disability and save a life. If you persist and stay, how should I put it, stay aware of the fact that if you don't understand what's going on or you're not getting results from the therapy, you have to try other avenues as well. So we know that the prognosis of autoimmune diseases has the best outcome with early treatment, and adverse prognostic factors are delayed diagnosis, delayed referral, which leads to late disease control and continued disease activity. And these two very important trials that were done in the 2010-11, which was the TREAT JIA and the acute JIA, showed that how early intervention with addition of a biologic, in this case anti-TNF, etanercept on one side and infliximab on the other, showed that there was earlier resolution of symptoms and earlier clinically inactive disease. And so the concept of treat to target came out in JIA as well. This is a very busy slide, but I thought that since the topic was biologics in JIA, just to briefly tell you that generally when we treat to target, we say that if the DMRs, and you try switching DMRs, over 3 months, if you do not achieve clinically inactive disease, you need to switch to a biologic, whether it's anti-TNF or in case of polyarticular course, you may try tocilizumab or tofacitinib. And if after 16 weeks of therapy there is still active arthritis, you switch to any one of these agents, you just switch it. While for polyarticular seropositive, rituximab is a choice, and it is available in Pakistan. And however, for juvenile psoriatic arthritis and ERA, a very great addition has been secukinumab and tofacitinib. So these are the GRAPPA psoriatic treatment recommendations, different domains. I just want to concentrate on 2 things, which are basically the enthesitis, of course, the axial disease enthesitis and dactylitis, as well as the skin. And many of you would have noticed how difficult it is to control sometimes skin psoriasis and dactylitis and enthesitis as well. And as you can see that over this course, all these domains are, responsive to other than peripheral arthritis, where you can do conventional DMRs. The rest, you need to add a biologic with it, anti-TNF or PD. Which is limited, of course, but sometimes nothing resolves the dactylitis or the enthesitis as well as tofacitinib sometimes and secukinumab. So treatment management in JIA, as I said, must have a treat-to-target strategy, and the targets are to control the signs and symptoms, to prevent, and when we say signs and symptoms, if you do a swollen and tender joint count, in polyarticular JIA, you need to have 3 or less joints, 5 or less joints, and if it is psoriatic or ERA, then 3 or less joints. You want to avoid comorbids and drug toxicity and optimize function, growth, and development, and the quality of life of these children. So the biological DMRs that So there are certain biological DMRs that have been approved in the US and EU, but I must say that many of us have been using them off-label in adult population as well, particularly in children, because you do not have that many trials. So many times the adult data is actually extrapolated onto the pediatric population. But unless they are approved, we generally like to keep it safe for children 6 years and above. However, now the good news is that we have etanercept, we have adalimumab, we have secukinumab, and we have tofacitinib. And tofacitinib and secukinumab both have been approved for younger age group in the EU 2+ and above, and in the US 4+ and 2+ and above. Otherwise, etanercept, adalimumab, when you look at the FDA approval indications, the children have to be slightly older. However, we are using them and it is good safety data. So when you look at registries or you look at case series, these agents have been used for children 2 years and above with good safety results. This is just an update on a 2024 article, and I just wanted to show you that if you have, for all GI types, of course, subcutaneous tocilizumab is preferred, and we have it. But for uveitis, if it is refractory, adalimumab is the first drug of choice anytime after 2 years of age, even when you fail one conventional DMR. For poly-GI or extended oligo, tofacitinib in patients from 2 years of age. And for psoriatic, secukinumab is the preferred choice before anything else from 6 years of age on once it has failed TNF inhibitors, or at least 2 of them. So in summary, we have 3 biologics, which are 2 TNF inhibitors and JAK inhibitor for the treatment of ERA or juvenile psoriatic arthritis. Etanercept, as I said, in the approved indications, has to be aged more than 12 years. Adalimumab for patients aged more than 6 years. And tofacitinib is available for patients aged more than 2 years. And I'll come down to secukinumab. It is the one biologic treatment that it is indicated for both ERA and juvenile psoriatic arthritis in patients which are younger, age 2 years or more in the United States. And we have used these in 1 or 2 patients with very good results. So when we talk of treat-to-target approach, again, the window for chances of inducing remission is greatest within early treatment, within months of disease onset. And it has been shown that delay in seeing a rheumatologist has a hazard ratio of 1.8 for not achieving drug-free remission, plus a 1.3 times higher chance of joint destruction. So the risk factors, as I said, delay diagnosis and delay access to appropriate therapies, inadequate specialist services, and especially children living in countries with worse socioeconomic status like Pakistan. This survey showed that we do not have enough pediatric rheumatologists who are trained, and definitely not globally. And in Pakistan, as you can see, most of us, actually all of us at the moment, are primarily adult rheumatologists who have trained or done some training in pediatric rheumatology. Even in countries like the first world, like Australia and New Zealand, this bar is the blue bar are those that are conventionally trained pediatric rheumatologists. And you see the orange bar is those who are either pediatricians or adult rheumatologists who are doing pediatric rheumatology. So even they have this problem. In India, who has actually very large population of pediatric rheumatologists, have a similar situation. So I think in Pakistan we have a lot more to go, but we are still doing not so badly. And just to show that, because of the CPSP recognition of FCPS rheumatology in Pakistan, and then more and more adult rheumatologists trying to clinically train or get access to training in pediatric rheumatology, we now have pediatric rheumatology experience in adult rheumatologists in faraway places, even as far off as in Peshawar and in Quetta and in southern Sindh and southern Punjab as well. And this is our rheumatology family, and most of these are fellows who have trained with us. I don't know, many of you are sitting here, so it is great to see this family growing every year. I just want to shout out to my pediatric rheumatology special interest group in APLAR, who have really, I think we have tried to expand training facilities which are out of the box for APLAR region. And I am so proud that two of my SIG members are here, Dr. Tahira and Dr. Taktis. And there is a remote learning webinar series which is every 4 months, and this last one actually had Tahira presenting, and it's a great resource. So I really would like all of you to, and it's free, would like all of you to try and attend these. Arthritis Care Foundation, I think one thing I am proudest to be a part of with Professor Nighat Mir. We sort of started this initiative, and then Ahmed and everyone else has carried it forward, and we try to give subsidized care or free care and treatment to children with rheumatic diseases, regardless of their ability to pay or access treatment. I just want to again acknowledge my mentors in pediatric rheumatology, mostly and primarily Professor Nighat Mir, who is sitting here, who made it possible for me to have the wonderful opportunities that were provided. These are our kids who actually, the one on the left was on, I think, tocilizumab. He had systemic JIA, and this was a polyarticular JIA girl who later turned out to have psoriasis and was treated with secukinumab. I think universally our children unite us. My wonderful colleagues who are working in our departments, Nighat and Ahmed, who are my comrades, Professor Tafazzul, Dr. Flak, and you see the center is where we are there for the CPSP exam, our PSR family, and of course then the APLAR family that I am privileged to be a part of. So I just want to thank you for your attention.